Morning, everyone. So if you all participated in the webinar last week, this will be a repeat for you all, but we're just going to cover a little bit about the CARA grant that we have and what it is about. So as Krupa mentioned, these are the three organizations that participate in this grant that we receive from the federal government. And so this is just the typical disclaimer that the information from this training does not necessarily reflect the views of SAMHSA, which is our funder. But the purpose of the First Responders CARA grant is to train, provide resources to first responders and members of other key community sectors to administer Narcan, and also establish process and protocol and mechanisms for referral to appropriate treatment and recovery services in the community that we serve. So the organizations that are part of it, as we mentioned, the lead organization is Elk Grove Police Department, and the subawards of the grant are the Kenneth Young Center and Live for Lolly. And the targeted law enforcement in the area are part of Elk Grove, Arlington Heights, Schaumburg, Rolling Meadows, Des Plaines, Palatine, Prospect Heights, Mount Prospect, and Hoffman Estates. And then the targeted communities that we work with are in the general Northwest suburban area of Chicago. So the staff that works with on the CARA in Elk Grove Village is the Deputy Chief of Police, Mike Gaspari. At the Kenneth Young Center is myself, the Division Director for the Community Collaboration Team, and Daryl Pass, the Manager of Recovery, and his staff, and then Laura Fry, who is the newly appointed Executive Director of Live for Lolly, and her staff. So why do we have, I have to move my pictures, why do we have a Northwest CARA? So one of the, when we submitted our grant, one of the things that we placed in the application is that 6 of the 9 targeted towns had a combined total of 98 overdoses in the last 2 years when at the time that we submitted the information. And then also based on information from PARI, which is a collaboration of different police departments, we know that the type of efforts that we are implementing through CARA, it can reduce crime rates and increases a person's use of substance seeking support services. It also increases community engagement in their recovery support services, and it also increases community partnerships. So here's some data that you all can just get a copy of this as part of the presentation. I won't go through this information, but the bottom line is that opioid overdose and use is on the rise, and it's definitely necessary for us to help folks in their recovery support services and also to provide people with life-saving naloxone. So our goal, our #1 goal, is to make sure that law enforcement carry and have access to naloxone by 2023. Those 9 villages that we mentioned, our goal is for 100% of law enforcement to have that on hand. So that would be us providing the training as well as the resources for them to have them as part of their uniform, as part of what they carry and have on hand. And then also to conduct community education and events, also to train village first responders beyond, just the law enforcement, but also to create and maintain a community resource guide for folks to find out how to get access to comprehensive recovery support services such as smart recovery, housing, education, other recovery support services that help them in their recovery needs, and then also to certify naloxone trainers to distribute over 24,000 naloxone kits, and then also to train over 300 individuals annually. So those are just some of the objectives that we have as part of this very ambitious grant that we received. And here's Mike Gaspari demonstrating how you can have Narcan as part of your life-saving device in your building. So our strategies are to make it available, to train and inform people about the Good Samaritan law, to train people about the different resources around, and please excuse some of the language because we have to use the language of our funders, but we also know that some of the language can be stigmatizing, but around the safety around what some call licit and illicit drugs, and also to establish, as we mentioned, protocol and around treatment and recovery, and to work with community advisor and coalitions in order to understand the importance of naloxone, and Narcan. So our requirement is to use FDA-approved overdose medication. We have available to us the nasal spray as well as the vials. We no longer have access to the Evzio because of its cost prohibitive, I would say. But those are the two examples of what we're able to provide through this grant. So if you're looking for training on naloxone, or you're looking to have access to the supplies and you live in the northwest suburbs, and your organization or a family member or individual in the area, as Laura will explain, just a person who knows a person or isn't, you know, I forgot Laura's saying, she'll tell you what it is. But anyway, just shoot me an email or give me a call, and we will see to it that you receive the necessary training and supplies in order to save a life. And without going any further, I will turn it over to Laura for today's training. Thank you.
Excellent. Thank you so much, Shireen. There we go. Yes, I am still a technological work in progress. Thank you for your patience. Good morning, everyone. I want to welcome back those that were with us last Wednesday for our first webinar Wednesday of Recovery Month, and welcome to new people. My name is Laura Fry. As Shireen shared, I am the newly appointed Executive Director of Live for Lolly. We are a nonprofit organization that works in not only northern Cook County, but collar counties of Cook County, McHenry, Lake, and DuPage County. Our goal is to work with people who use substances and the people who love them. So today we're going to be talking about overdose, education, prevention, and how to reverse an overdose. Some of this, depending on what your position is within your work world, you might already know. But we're going to talk about what opioids are, how they work, how to identify if someone is intoxicated and or overdosing, a baseline understanding of the overdose epidemic that we are in. What is harm reduction? I'm going to go into that a little bit because next week's webinar is all on harm reduction. So we'll be taking a deep dive next Wednesday. We're going to talk about how to become familiar with overdose prevention and the policies around that, how to respond and reverse an opioid overdose, and what is naloxone, how, what, where, and when. Today in America, this is the average number of people that will die from a drug overdose, 192 people. Every day, yesterday, tomorrow, next week, 192 people. This does not include alcohol-related deaths. If we added alcohol deaths to this number, we would be well over 300 a day. In the Chicago area, in the state of Illinois, that is more death than we see in gun violence and car accidents. It is the #1 accidental death of people under the age of 50. In 2019, we lost 2,098 Illinois citizens from an opioid overdose. Slightly down from the year before, which means that we're going in the right direction. However, this year, with the onset of COVID and the isolation we've all experienced, we are going to see this number exponentially higher by the end of the year. Illinois Department of Public Health last week came out with a statement that they are seeing in the city of Chicago a 50% increase in opioid overdose. And the rest of the state is hovering around 33%. So this is, we're in a crisis. We're in an even bigger crisis. This is an epidemic within a pandemic, or a pandemic within an epidemic. Not sure which way that goes, but we're in a crisis. I wanted to show a chart of trends and point out that the age range, we might think that this is young people that are dying from opioid overdose, but really it's between 45 and 54 years old. And this is exponentially happening to our Black and brown friends. I think the figure is 7.6% higher among our Black and brown communities. This was the data from last year, and I wanted to point out where we saw the biggest jump is how many of these overdose deaths were opioid related. Over 70% of the overdose deaths in this country were opioid related. And I point that out specifically because what we are seeing here on the street is a lot of fentanyl. We are finding fentanyl in every possible street drug you could imagine, from ketamine to LSD to Xanax. Any street drug has the potential to have fentanyl in it. And when you're going out and doing cocaine, what you're not expecting is an opioid. And that is why we have seen these opioid-related overdoses increase so drastically. So let's talk a little bit about the scope of the problem. What we know from the CDC is that most youth obtain their first substances, if you will, from family or friends. Now, that doesn't mean that Aunt Mary has your kids over and she opens up her medicine cabinet and says, help yourself. What this indicates is that we, as adults, need to keep better track of our medication. All medication, whether it is a blood pressure medication or Norco from your dental surgery, all medication should be locked up or kept inside your bedroom or somewhere where other people cannot get to it. Even if you think that the medications that you take daily are benign, what we know from people who have shared stories is that just about anything has a street value. Just about anything can be traded. Another comment that I've heard from a lot of the youth in our area is that they participate in farm parties where everyone brings whatever it is they have, put it into a big bowl, and then they help themselves. So it is really, I implore, if you take nothing else from this today, go home and do a quick check of your medicine cabinet and lock it up. Get a lockbox or some other way to keep your medication out of the hands of anyone but the person it's prescribed to. What we know from NIDA is that prescription narcotics are the fourth most commonly misused drugs by teens. And narcotics, there's a wide range of products that fall under narcotics. Prescription pain medication, they're talking about benzodiazepines as well as stimulants like Adderall and Ritalin. This young adult age group is the highest reporting age group of people who misuse prescription medications, and not necessarily medications that are prescribed to them. I mentioned this earlier, there are more overdose deaths in the United States than from car accidents and gun violence combined. And I know here in Chicago, every single day it's what was the gun violence that happened the night before. What we don't talk too much about is what were the overdoses the night before? And that really needs to become a priority. This statistic was taken from a youth survey. The number of adolescents between 12 and 17 who report prescription narcotic misuse. I sometimes feel this number is a little misleading because in a lot of the kids that I've talked to, they're like, oh, we just click through that, we don't even read it. So I don't know how effective this number is. I would guess that it's a lot higher than what is reported. 1 out of 8 high school seniors, according to NIDA, report non-medical use of prescription opioids. Kids sharing their medication, kids taking their parents' medication and sharing it at school. 1 in 8 is a huge number that we really should all be very concerned about. I know this number might be hard to wrap your head around, but what I want to say about this is the United States makes up 5% of the entire world's population, only 5%. Yet, we give out 85% of the world's opioids. Other parts of the world do not deal with pain the way we do in this country. It seems to be the first line of defense is to prescribe an opioid. So keep that in mind. 5% of the world's population, yet we write 85% of the world's opioid prescriptions. I know that some of you are from outside of Illinois, but a lot of our work is focused within this state, so I wanted to share some Illinois statistics. The Chicago metropolitan area has been ranked first in the nation for ER visits that are associated either with overdose or substance-related health concerns like abscesses or a seizure. The Chicago metropolitan area is number 1. However, that being said, Illinois has also seen a 52% decrease in just 5 years of treatment options. Those two things don't seem like they go together, do they? And why is Chicago metropolitan area a hub? The reason is because we have a very good infrastructure set up. We have railway, waterway, an international airport, and a very good highway system. So that makes us a hub for things to come into Chicago and then go out. One thing that we did very well is we disposed of a lot of unused prescriptions. So that was really good. Illinois made up 21% of the nation's total. If you have medication at home that you are no longer using, please find out where you can safely dispose of that. Do not flush it down your toilet or throw it in the garbage. Many pharmacies have medication kiosks where you can drop off old or outdated or medication that you don't need. A lot of police departments as well have a mailbox that is set up to receive medication. If you are not using a prescription, I ask that you please get rid of it. There are also products I know we have a product, and I know that Kenneth Young does as well, that you can add to a prescription bottle that renders medication useless. If you cannot find a drop box, please get some of that. Walmart, I don't know if it's throughout the country, but Walmart in my area gives out packets of this product so that you can get rid of the medication when you're done with it. So what we know, what the statistics tell us, is that 80% of new heroin users began misusing prescription opioids first. The Midwest, in less than a year, showed a 70% increase in opioid overdoses. There were 16 states throughout the country that saw a giant increase in opioid overdoses within their large cities. And I just added these last two bullet points yesterday because I thought they were so important. With an estimated 21.2 million people needing treatment, that's 1 in 13, only 1.4% received any treatment. I mean, just think about that. Wrap your head around that. Could you imagine if 21 million people had cancer and only 1% of them, or a little over 1%, were able to get treatment? That is shameful. So with so much overdose going on, why aren't people calling 911 like for any other medical emergency? Why is this different? Well, there's a lot of reasons that go into that, and a lot of it is systemic. Fear of engaging with law enforcement because of prior engagements, a warrant, because especially in this day, engaging with law enforcement can be a scary thing. People don't want to get arrested. People don't want to get charged with drug possession or drug-induced homicide. There's also a big lack of knowledge that an overdose is even going on. We work with a lot of families who have lost their loved ones to overdose. And some of the things that we share are like, and I'll get into this later, snoring sounds are not really snores. It's an overdose. And a lot of people do not know what the signs of overdose are. So they let people sleep it off. Or they try home remedies like putting people in a cold shower, or trying to get someone to drink coffee. Those home remedies really don't work. And it's estimated that 911 is really only called between 10 and 56% of the time, which I know is a large difference, but it's hard to get accurate information on who is calling 911 and who is not. So we need to really encourage people to call 911 when an overdose is going on, and to realize that it's the better of all options, because people are going to die. So what are some legislative supports that are set up for overdose prevention? Again, some of this is going to be very Illinois heavy, because that is the area that we're in. In Illinois, we have the 911 Good Samaritan law. This was passed in 2010 along with the naloxone access law. What the 911 Good Samaritan law says is that you and the person overdosing will have limited immunity for any prosecution. So if you are the person calling and your friend is overdosing and you've both used, you will not be prosecuted for that. Small amount of drugs depends on what the substance is. You know, of course, if the police respond to an overdose call and there is kilos of cocaine sitting around, that's a whole different story. But in good faith, if you are calling 911 because a friend is overdosing, you are not going to be subject to prosecution for that call. This law is currently being looked at and is going to be, I don't want to say redone, but it's going to be more defined, especially with cannabis being legal now in the state of Illinois. That used to be the only drug that was not covered under the 911 Good Samaritan law. So we are looking at this law. We're working with some legislators on beefing it up a little bit and defining it a little further to help not only people who call 911 during an overdose, but also law enforcement. So who gets protection? Only the caller and the person overdosing. It does not provide immunity to a whole house full of partiers. If you are in a situation where someone is overdosing, it's best for other people to leave when you call 911, unless they are also in danger. This also applies to an alcohol overdose or alcohol poisoning that involves a minor. And this is part of the law that we're going to be trying to further define. Does the law always apply if the person dies from an overdose? A lot of that is left in the hands of the county prosecutor. And we want to help them better define what drug-induced homicide is and what it is not, because we don't want people to fear calling 911 when someone is overdosing. This is resulting in so many deaths, fear of interaction with law enforcement, and that's not how it should be. As of December 2018, 46 states plus the District of Columbia currently have 911 Good Samaritan laws. Should be 50, I know, but we're getting there. This has really increased the last few years that I've been involved. Many, many states are stepping up and recognizing that without a 911 Good Samaritan law, people are not calling. And our overdose death rate is going up higher and higher every year. So in summary, our law here supports not only calling 911 during an overdose, but it recognizes naloxone as a standard tool that can be used by all lay people. There is no age limit. I'm sorry, there is no age limit to this. There is no liability or punishment if you use it. The youngest person I've trained to reverse an overdose was an 8-year-old girl whose mother was a person who uses heroin. And she was the only one there that could respond. So we trained her in how to recognize an overdose, how to call 911, and how to reverse. So if you can comprehend the signs of overdose, then you can use naloxone. This, I wanted to talk a little bit about OUD or opioid use disorder and try to explain how opioids hijack the body, hijack the brain. There is a strong desire to continue to use, and efforts to try to cut down or to control the use are usually not very successful. withdrawal from opioid use disorder is extreme. I've had participants explain it to me in various ways that even their hair follicles hurt. It is the worst flu you could imagine times 1,000. I had one person tell me their bones felt like they were shards of glass rubbing together. So it's no wonder. Who would want to feel like that? I'm sure everybody here has at one point or another had the flu. It's miserable. And I think people would do just about anything to not feel like that. And this is why opioids in particular are incredibly difficult to remove from your life once you have misused them. Tolerances are developed. More and more is needed from day to day, and it's tough. So why do people take drugs? Probably as many reasons as any of us could come up with. A lot of times, substance use disorder involves trauma, childhood trauma, adverse childhood events, to try to feel different. As humans, as the human race, we have been trying to alter our consciousness since we crawled out of the cave. That's why I don't know who here has one of these with them. I have one with me all the time because I need to be caffeinated, and caffeine is a drug, and I ingest caffeine to alter how I feel. Really not that much different from a person's reason for using any substance. We want to feel good. We want to escape problems. We have underlying mental health conditions that have not been properly diagnosed that we are trying to self-medicate. And eventually we want to avoid that withdrawal process because it's horrible. So what is an opioid? Opioids are considered sedative narcotics. They're primarily used to treat pain. I have really been surprised in the years that I've been involved, the number of people who really don't understand what an opioid is. Tramadol, Norco, Percocet, Dilaudid. They are all on the same chemical chain as heroin. They all do just about the same thing. Opioids create a sense of euphoria, warm, drowsy. And they also vary in their duration of action and how long it takes to metabolize out of your system. Potency can be influenced by how substances are ingested, the general health condition of the person, and sometimes how hydrated are you. It's very, goes all over the board. And what opioids do, they depress the central nervous system. And the central nervous system is what regulates our ability to breathe. So opioid overdose is a condition of hypoxia or lack of oxygen. So opioids come in 3 different families: natural, semi-synthetic, and fully synthetic. Opioids and opiates are similar, but only opiates are the natural one. And that only consists of 3 things: opium, morphine, and codeine. And then in the semi-synthetic, we've got your heroin, hydrocodone, oxycodones, the codones. And then fully synthetic is fentanyl, methadone, and Demerol. So why is that important to know? Anything that is fully synthetic can be recreated anywhere. This is why we are seeing such a fentanyl crisis and the fentanyl analogs. They can be created anywhere. You don't need to grow a poppy plant to create opium. It's really important to know. Any substance that is fully synthetic can be made in your kitchen or in a home-built lab. So this is a really good chart that I love to use. It shows a range of opioids from methadone to fentanyl. Methadone is the longest duration opioid on this chart. It lasts 24 hours. It is a very even level coverage, and this is what makes methadone such an excellent medication for opioid use disorder. You'll see that heroin is a little more potent, lasts 6 to 8 hours, but look down at fentanyl. Fentanyl has a very short duration. It's used in the medical field, oftentimes used on ambulances for acute and catastrophic injury because it works very quickly, but it doesn't last long. But look at the potency. Fentanyl is 50 to 100 times more potent than heroin. This is why we're seeing such a fentanyl crisis. Oh, there I went and got ahead of myself again. Like I said, fentanyl is fully synthetic, which means it can be reproduced anywhere. 50 to 100 times more potent than morphine. Most fentanyl is illegally manufactured. It plays a huge role in the medical field for anesthesia, surgery, acute injury, but much of it is manufactured illegally. The increases in overdoses have been associated with these synthetic opioids. When you look at reports from the coroners in our area, this is what we're seeing. We're seeing fentanyl analogs. When we test people's heroin, we're finding fentanyl in everything. It is very difficult to find a pure substance out there on the street anymore without fentanyl being in it. We are seeing fentanyl responsible for well over 50% of the opioid-related deaths in our area. So how do opioids affect the body? I come from an ER nursing background, and I would always share with my patients because people don't understand how opioids affect the body. Opioids attach to proteins called opioid receptors in our brains. Opioids work in our brain, they do not work at the site of injury. The purpose of an opioid is to attach to these receptors and reduce the perception of pain, but not pain itself. So if you break a bone, you might want to think a little bit about what medication you take. Do you want to take a medication that's going to reduce pain and inflammation at the site of injury? Or do you want to take a medication that's going to make you think you're fine? That's how opioids work. Opioids produce drowsiness, confusion, constipation. Sometimes opioids, I know that they do this for me personally, they instigate a histamine response, and sometimes you get itchy. So you might have heard of people with opioid use disorder picking or scratching. That is why. Opioids affect the brain's reward system. They make you feel like everything is going to be okay. And because it impacts your brain's reward system, the brain can be a lazy organ. If you are flooding your brain with opioids and this euphoric feeling, the brain says, oh, I don't have to create dopamine anymore because I'm being flooded with it, so it shuts down. This is part of the withdrawal process. Your brain is not producing these chemicals that we need to survive. There is dependence and tolerance for all medication. I am dependent on my thyroid medication, for example. Every 6 months, I have to be retested to see if I've built up a tolerance, at which point the medication would have to be increased. We see that with beta blockers that are used to control high blood pressure. We also see this with opioids. People build up a tolerance after they become dependent, and they need to take higher quantities of the drug. And this isn't only people who misuse substances. We see this in chronic pain patients continuously having to be increased because the medication stops producing the same effect or reducing the same amount of pain that someone is used to. And taking the same dose for a long period of time leads to diminished effect, which means it has to be increased. It's a vicious circle. Some behaviors that we see associated with substance use disorder: people taking medication differently than prescribed, people using medication in a different way. Instead of a pill form, they start crushing that pill and then snorting it because it gets into the system faster. And eventually mixing it with water and injecting it. In the hospital that I worked in, we would hear a lot of reports of people losing their prescriptions or having them stolen. A lot of what's called doctor shopping, people going to numerous doctors for the same complaint and getting a number of prescriptions. About 3 years ago, Illinois passed the prescription monitoring system, which emergency rooms, doctors, and pharmacies have to prescribe to so that they can look up a person's history if something sounds a little off. And this was instigated not to cut people off, but we would use this as an opportunity to talk to a patient about the number of ER visits that they've had in the past month, and this might be a bigger problem than you're presenting with. Opened up an opportunity for conversation and to better help people. The risk factors are almost as long as the reasons why people use substances. Genetics, we know, plays a large role, can play a large role, not always. Family history, having a chemical balance, having a traumatic brain injury, very often underlying mental health disorders, disorders that are not easy to diagnose. Any illness that is life-threatening or chronic or associated with pain. We want to get away from that, right? Just as a normal human, we don't want to be in pain, whether it's physical or mental. We don't want to be in pain. So that puts us at risk. Some other factors that could come into play: environment, learned behavior, but not always, exposure to trauma, adverse childhood events, having a volatile family life, availability. Sometimes it's just a matter of availability. It's in the house, everyone else is using it. This must be what I'm supposed to do. Many, many reasons for misusing substances. And then we see a lot of co-occurring disorders. And it is sometimes very difficult, and with the clinicians at this webinar, I know that everybody would agree, it's hard to try and figure out what came first. Was someone experiencing a mental health crisis and trying to get through it with substances, or did the substances create a mental health crisis? Sometimes it's important to figure that out, sometimes not. Some substances create an increased risk of mental health symptoms like psychosis. We see psychosis and hallucinations in people that are using methamphetamine. We've seen cannabis psychosis in adolescents or people who don't have a properly developed brain yet. Oftentimes, people use substances to deal with a mental health disorder as a form of self-medication, because sometimes it can be very difficult not only to diagnose, but to get the right cocktail of medication that's going to help you to feel better. I've been through this myself. Self-disclosure, I am a mental health survivor, and sometimes it takes a lot of different combinations. And try this for 3 months. Oh, that doesn't work. Try this for 3 months. It takes a long time. And sometimes when you are suffering, being able to use a substance that works like that is a lot more palatable than having to go through a year of trying various different combinations to feel better. Nobody wants to feel like that. Oftentimes, co-occurring disorders are difficult to diagnose because of complexity of symptoms. If we treat one disorder, if we treat substance use disorder, but don't also treat the mental health issues that are going on, it's not going to work. What we know is that people with co-occurring disorders are best served by integrated treatment that cover everything: holistic treatment, housing, employment, mental health, substance use disorder. If we address everything, we see that people have better outcomes. We cannot take care of, it's like putting a Band-Aid on an amputation, hoping that it holds, but most likely it's not going to. That's the same thing with trying to treat someone that has multiple co-occurring disorders and you just pick one of them. So some points to remember: comorbidity is 2 or more conditions that appear in a person. Substance use disorder and mental health issues are common. About half of people who have one also have the other. And SUD and mental illness have so many of the same risk factors. Oftentimes, people with mental illness might be predisposed to having substance use disorder and vice versa. Treatment should focus on both mental health, wealth, and substance use together instead of one versus the other. And we need more effective behavioral health treatments and medication that are going to address both issues at the same time. I believe, and this is what the data tells us, that this very well might be why we see people circle through treatment so many times. The average is 9 treatments before someone enters sustained recovery. 9. Why is that? That's terrible. I don't have all the answers, but I do know that we need to start looking at people as whole individuals and addressing comprehensively everything in their life to give them the best footing for recovery. So many of us are not getting into our cars and going to work anymore. But if you did get into your car today to drive somewhere, I am guessing that you put one of these on, a seatbelt. A seatbelt is harm reduction, as is airbags and vaccinations and sunscreen and fluoride in our toothpaste. Anything that we do to reduce harms is harm reduction. When we get into our car, we don't think, I could get into a fatal car accident today, so I'm going to put my seatbelt on. It's just automatic. So what does harm reduction look like in substance use? Many different things. Disposing of unused medication. Having a lockbox. That's harm reduction, potentially reducing the harms of someone else getting your medication, right? Fentanyl test strips. Since we started giving out fentanyl test strips 2 years ago, we have probably given out about 6,000. And these are very simple dipsticks where you can test your substances to see if fentanyl is potentially present. Safe injection supplies. Last August, the state of Illinois signed into law that syringe exchange is legal within the state of Illinois if you are obtaining your supplies from a registered safe supply program. Live for Lolly is a registered safe supply program with the state of Illinois. So we are able to give out safe drug-using supplies and safe life-saving supplies like naloxone as part of our harm reduction program. Rotating veins. I tell you, all of my nursing background, I did not think that I would put it to use in teaching people how to use substances safer. But that's what harm reduction is all about. How do we keep people safe right now, in the moment, until they make a change? Sharps containers. Our mobile outreach program also gives people personal sharp containers so that they can return their sharps to us and we can properly dispose of them. Takes things out of alleys, off the street, and of being disposed in a way that could cause harms to others as well. In March of this year, Live for Lolly launched our mobile outreach project. What we found is that our office in Arlington Heights was not easily accessible. So we needed to go to people. We currently have a location in Lake County and McHenry County. In the very near future, we're going to be at a location in Schaumburg, and then we're going to be adding a location in DuPage County and hopefully in Evanston, taking services to people, not waiting for them to come to us. Some of the services that we offer in harm reduction: not only safe using equipment like syringes and water, safe smoking equipment like crack use equipment. We give out safe sex supplies. We give out toiletries. When people are housing challenged, food challenged, do not have access to things that we get up and use every day, like deodorant and soap and sanitizer and masks, that creates a barrier. So on our mobile outreach and in our harm reduction program, we give out all of these things: naloxone, fentanyl test strips. We are still working on getting HIV and Hep C testing available on the mobile outreach. We're going to be adding that very soon. We occasionally have medical professionals come out and allow them to do basic medical evaluations on people, to check on abscesses, to look at people's foot care. And all of our staff are trained in motivational interviewing and peer-driven cognitive behavior therapeutic techniques and rational emotive behavior techniques. And the most important thing that I feel harm reduction does is provides connection. And when we connect with humans that are struggling, we can offer linkage to care and any other services that they might need. We're going to start a register to vote campaign through our mobile outreach to get people registered to vote. We transport people to treatment and do treatment navigation. We provide case management if people are in need of housing, if people are in need of medical help. I am going to stop my video because my internet is a little wobbly right now, and that might make it better. So harm reduction in our world is not just handing out clean syringes. It's that holistic, comprehensive, personal approach that I've been talking about throughout this presentation. If we don't address a person as a whole, the other little pieces that are all interwoven and connected aren't going to work. This is a close-up of the fentanyl test strips that we use. Very simply, whatever substance you have, whether it's a Xanax bar or a baggie of cocaine or a dropper full of LSD, you can dump it out, add water, put in a fentanyl test strip. One line indicates that fentanyl is present. 2 lines means that fentanyl is not present. Currently, these strips test for fentanyl and 38 analogs. The bad thing is that analogs are continually being developed. Home chemists can tweak a chemical chain and change up an analog, thus making it more difficult for the DEA to track it. So there are some analogs that could be falling through the cracks, but it's something, and it's what we have. And we encourage anyone, even your once a year weekend cocaine warrior, should be testing their substances before they ingest. So what puts people at risk for opioid overdose? Previous experience with non-fatal overdoses. Again, the brain being a lazy organ. When you have multiple non-fatal overdoses piled up on each other, the brain is like, oh, I know what I'm supposed to do here. I'm supposed to go to sleep. So non-fatal overdoses bring you closer to a potential fatal overdose. Combinations. When we work with people who use substances, we ask them to stick with one thing. If you're going to be using benzos, don't also boost that with heroin. Alcohol is also a central nervous depressant. So don't use alcohol if you're taking pain medication. Cocaine and opioids, oftentimes called a speedball. I've had people who use drugs tell me that that balances them out. It is the worst thing possible for your heart. Your heart doesn't know what to do. Do I slow down? Do I speed up? What do I do? So any combination. There can be a variation in purity when you're purchasing your medication, your substances on the street. These are not pharmaceutical companies that are making these under strict rules and regulations. So you can go from one block and purchase something and go 2 blocks over and get something completely different. We see a lot of fatal overdose after a prolonged abstinence. So someone coming out of jail or prison, very pivotal time. Someone just released from treatment with no continuing plan. It's also a very pivotal time for overdose death. So this is, again, what I mean about wraparound treatment, continuity. People need connection. This isn't a 30 days in and done. Connection and treatment needs to continue. People cannot be released after 3 years in prison with nothing. This is when a reoccurrence of disease occurs. Without medication-assisted treatment or medications for opioid use disorder, and I know I said this earlier, on average, people require 9 years or 4+ treatments to enter remission. And I think 4 treatments is a pretty low number with the current data available. Multiple occurrences increase your risk for opioid overdose. Using while alone, we always ask our participants that we work with not to use alone or let someone know, even if it's to call us and say, listen, I'm going to use, can you call me back in 15 minutes? Any kind of poor physical health, if you had the flu, that can impact how even a substance that you use regularly might interact with you. Are you on a new medication? Have you had a recent loss in weight? Are you somewhere else and purchasing from a new dealer or using a new product? Are you switching from modes? Are you going to injecting when you've only snorted? People that ingest opioids for long-term management of chronic pain. or cancer conditions, MS, increased risk for overdose. And like I said in the last slide, low tolerance, just coming out of jail, treatment, or any period of abstinence. Sudden use, people go back to what they were using beforehand. And now that they don't have a tolerance built up, that is the perfect storm that could lead to overdose. And unfortunately, this is 1000% true. There's really only two responses to an actual opioid overdose. One is death, and the other one is a human responding with naloxone. I know that this is a little outdated. It's really difficult to get these statistics. What we are saying is a vastly increasing number of opioid overdoses being reversed by lay people, which tells us that community naloxone distribution programs like ours are working. We are seeing a lot more doctors and pharmacies giving naloxone to patients that are on opioid therapy for some other chronic condition, and teaching them that opioid overdose can occur in anyone who uses an opioid. It is not just street drugs or illicit drugs. Anybody who uses an opioid has the potential to overdose. When I was working in the ER, my oldest overdose patient was an 82-year-old patient who got confused with when she took her medication last, and did that 3 times in a row, and was found by a family member in respiratory arrest. So it can happen to anyone. So how do we respond to an overdose? One thing that I was pretty surprised, I recently got recertified in CPR since I left my medical job. And I was pleasantly surprised to see that the American Heart Association is now teaching, if you come upon someone who's down, to assume an opioid overdose. They are talking about naloxone as part of CPR, which I had never seen in all of my medical career. It was always assume a cardiac situation. But now, because of the crisis that we are in, the overdose crisis that we are in, we are to assume that this could possibly be an overdose. So some signs of opioid intoxication are pinpoint pupils. This is pretty much the only substance that will pin your pupils regardless of the lighting that you're in. Typically, our pupils get bigger when we're in a darker setting to let more light in. If someone is using opioids, their pupils will be pinned. Whether it's medication that's prescribed or medication that's being misused, opioids will pin your pupils. Some of you may have heard of nodding. I have literally watched family members nod out right into a plate of food. My son is my biggest mentor when it comes to these kinds of things. He is in remission from heroin use disorder, and everything that I learned during his time of using, I now use to teach other people. So the nodding is very typical. People are sleepy, slurring of the words. It's sounds a lot like alcohol intoxication. And I talked earlier about the histamine reaction. There is oftentimes a lot of scratching. I know that when I've had surgery, I have to be pre-treated with Benadryl before being given an opioid because of this allergic reaction. So you'll see a lot of scratching. Breathing is usually reduced. So typical respirations are between 16 and 20, let's say. So when someone is under opioid intoxication, their respirations might slow, but they're still over 8 per minute, and that's an important number. So what's the difference between intoxication and overdose? Some things are the same, but there are some differences. You're still going to see pinpoint pupils, but people are not arousable and do not respond to painful stimulus. So we teach people a sternal rub. If you take your knuckles and rub it across your sternum, it's uncomfortable. People who have just nodded out will wake up when you do that, or knuckles under the nose. People who are in opioid overdose will not respond to painful stimuli. Breathing has either slowed to under 8 per minute or has stopped altogether. Choking and gurgling sounds. It almost sounds like people are snoring. And I'll never forget a mom that I met when I first started working with Live for Lolly who talked about sitting on the couch and hearing her son down the hall snoring, and she was happy that he was finally resting. What she didn't know is it was agonal breathing, and his brain was trying to bring in as much oxygen as it could. So snoring in someone who uses opioids is not a good thing. Does not mean they're sleeping well. Skin can become cold or clammy. And on lighter pigmented skin, you will see the lips go blue, but you can also check the nail beds. Nail beds on any pigment of skin will appear blue. That can indicate an opioid overdose. But in particular, remember painful stimuli. People in overdose do not respond to pain. And that does not mean that you slap, kick, punch, or pinch people. A nice sternal rub or a little pinch under the arm will usually elicit a response. So naloxone. Naloxone and Narcan are the same thing. Narcan is a brand name, kind of like tissue and Kleenex. Naloxone is the medication. Narcan is the nasal brand. It is referred to as an opioid antagonist. What that means is that it reverses opioid overdose. All opioids, whether it's Norco or whether it's fentanyl, it has the potential to reverse an overdose. What we're seeing, because there's so much fentanyl in everything, is that oftentimes it takes more than one dose. It can take 2, 3, 4, sometimes 5 or 6 doses. Naloxone goes to the receptors in the brain, knocks the opioid off, and covers it, so that the opioid is still in the brain. It doesn't get rid of it. It just knocks it off the receptor and covers it. It temporarily allows an overdose patient to breathe normally. Starts working within 0 to 3 minutes, but, and this is one of the most important things, it only lasts for 30 to 60 minutes. And then it dissipates in the brain. The opioids are still in the brain, and they will reattach to the receptors, and oftentimes people will re-overdose. So calling 911 first is the most important thing you can do. You can't give too much of it. If one doesn't work, give another dose. Two doesn't work, give another dose. Usually by that time, EMS and or the police have arrived and they carry naloxone. If this isn't an opioid that's ingested, it will have no effect. It will do absolutely nothing. Naloxone cannot be misused or abused. It does not cause overdose. Excuse me. And it's only effective on opioids. So what if you don't know? What if you don't know if opioids have been ingested, if there's no paraphernalia laying around? It is best to use your naloxone and take the opioid out of the equation. It's not going to hurt anything if you use it. It will have no effect if opioids are not ingested. And, you know, take the opioid out of the picture. Oh no, what happened? I apologize. When we do naloxone training, we teach the SCARE ME acronym. So you can just remember that. Stimulate. If there is no response, call 911. First and foremost, call 911. Check the airway. Oftentimes, opioids will cause someone to vomit. So you want to check the airway so that you're not blowing it back into their lungs when you try to save them, right? Communicate with EMS what you've done. It's good for EMS to know that you've already given 4 doses. That might indicate to EMS that there's something else going on. So you're going to come upon someone, you're going to stimulate them, they aren't responding, you're going to call 911. Check their airway. And like I said earlier, opioid overdose is a condition of hypoxia or lack of oxygen to the brain. So we want to provide some rescue breathing. Sometimes people are hesitant to do that when they come upon a stranger that isn't breathing. I carry a face shield in my purse. They're very cheap and easy to get. You can also throw your t-shirt or whatever it is you're wearing over someone's face and breathe through that. We want to get oxygen moving. If they are not responding to your painful stimulus, if they have not responded to you giving them a couple of rescue breaths, then you're going to use your naloxone. So again, going over the steps for responding to an overdose. Provide a sternal rub. There's no response. Call 911. Always call 911. Give rescue breaths. If breathing is less than 8 per minute or non-existent, you want to roll the person on their back, open their mouth, make sure there's nothing in there. And just like you would in CPR, lift the chin, pinch the nose, and give 2 quick breaths. We recommend people continue the rescue breathing pattern until the victim has either started to breathe on their own or EMS arrives, alternating with administering naloxone. So breathing for a person, giving naloxone. Breathe for them again, give a second dose of naloxone. And the saying that I always use that Shireen was trying to remember was, my theory is if you are a human and you encounter other humans, then you should carry naloxone. Why not? gives you the opportunity to save someone's life. And you don't necessarily have to have people in your home or in your personal life that are using opioids. Just in my family, my son has reversed an overdose in a Starbucks parking lot, and I reversed 2 people overdosing at a forest preserve that I was hiking in. I came out to the parking lot to get into my car and found 2 people slumped over. So you want to be able to save someone's life if you can, don't you? I do. After administering naloxone, support is needed. There is a myth out there that people come out of overdose punching and kicking and fighting. In 15 years of working in emergency medicine, I never saw that. Typically, when people come out of an opioid overdose, when it's reversed with naloxone, naloxone causes precipitated withdrawal. So a person is in withdrawal. And if you've ever seen anyone in opioid withdrawal, they are in no fighting condition. What might happen is vomiting. So I do recommend that people step to the side and anticipate that vomiting might happen. We recommend that you consider continuing to administer naloxone and give rescue breaths until EMS arrives. Try to keep the person calm. Remind them that help is on the way. If a second or third dose of naloxone does not revive someone, then there might be a few things going on. Either they've been down too long and the heart has already stopped, there are not opioids in their system, or it was something non-opioid related that was the primary cause. After reversing an overdose, we recommend people be placed in the recovery position. That is, in case vomiting does ensue, people don't aspirate back into their lungs. The recovery position is on the left side with the hands supporting the head. You want the heart and the brain on the same level. It helps with recovery from overdose. Prop a leg out in front of them so people don't roll over. And evaluate. Not only evaluate the person, but evaluate your demographics. You know, did you come upon someone who was in a car and did you pull them out? Are you in danger of traffic? What are your surroundings? So not only evaluate the person that is overdosing, but evaluate your own safety and your location. Can EMS find you quickly? Or are you in the middle of a shopping mall and don't know what store you're in? Or are you in the middle of a forest preserve hiking? So be aware of and evaluate not only your patient, your quote unquote patient, but your surroundings as well. We share with people that using again will only make the overdose worse when naloxone wears off. Remember, people who are given naloxone are put into precipitated withdrawal, which we already know is the worst possible feeling ever. So people don't want to feel sick, they want to use again. As the naloxone dissipates, the opioid effect will start to take over again, so people will start to feel better. Hopefully by that time, 911 is there and you can hand the case off. So again, we come upon someone, we're going to check for breathing. They're either not breathing or not breathing well. We're going to provide some painful stimulus, see if we can arouse the person. I came upon someone in downtown Chicago that I walked past and I thought, wow, I wonder if this person is overdosing, and I always carry naloxone with me. So I kind of shook this person and they were just deeply sleeping, and I really surprised and probably scared him a little bit. But you know, you can't just walk past someone who's slumped over. I can't. If the person does not respond to stimulation and is not breathing well, you're going to provide rescue breathing. You're going to administer your naloxone and monitor for a response while checking your surroundings. You're going to provide ongoing support and monitoring the individual until EMS comes. Always remember, after you provide stimulation and check for breathing and a person is not responding, you're calling 911. And any other interventions as indicated, if, you know, having to do with your surroundings. If it is in the middle of traffic, get out of traffic. If there is paraphernalia around that you're afraid you're going to get stuck with, kick it out of the way. Any other intervention that you think might be needed. And whenever you get naloxone from a program like the Northwest CARA program or Live for Lally or any other organization, we do need to complete naloxone administration records. So if you do decide that you want to carry naloxone on you, that will be gone over. Some important things to know about naloxone: they are temperature and sun sensitive. So they need to be kept somewhere between 59 and 86 degrees on the far end. It has to be kept out of direct sun, so we don't recommend people keep it in their car. Naloxone seems to be much more impacted by heat than cold. However, it should not be kept in your vehicle or in your kitchen window. As with all medications, keep away from children unless you've trained them on how to reverse an overdose. And one thing the manufacturers tell us, if kept in the right conditions, if kept out of the sun and in the right temperature, naloxone will be effective 5 to 10 years beyond the expiration date. So if you have some that's expired, but you know that you've kept it in the proper way, it will still work. This is what the 3 versions of naloxone look like. We have the nasal spray, which is all in one. The medication is within the nostril piece. You just stick it in the nostril and push the plunger up. The one in the back, the yellow and purpley one, is the FZO auto injector, which is much like an EpiPen. You can open it up and it talks to you, but it is very expensive. So the only time we get to have that is when we wind up receiving a donation of expired FZO from a health department or police department. The one that we typically use a lot of here at Live for Lally is the old standard that's been around since the 70s. Naloxone in a vial that we draw up into an intramuscular syringe and inject it into a big muscle. It's the gold standard, works very well. They all work very well.